Good afternoon. I'd like to thank the organizers of this huge scientific conference to have me included in the presentation. So both Professor Zamer and Professor Clemenson made it easy for me because I'm dissecting their clinical trial. So if I say something good, please be nice. And if I don't say something good, also please be nice. The ECLS shock trial long-term result. We always obviously look at the headlines. The headlines of the ECLS shock and the danger shock maybe not as important as Men Won't Walk on the Moon, dating back to 1969, but both clinical trial, to my knowledge, even though one quote-unquote negative and one quote-unquote positive trial, I think they both have impacted the field of cardiogenic shock significantly. Obviously, we know the cardinal sin in the cardiogenic shock is the low cardiac output, and any device that we want to use needs to give us better cardiac output and better end organ perfusion. And of course, we have an area of mechanical circulators support, and I know Dr. Peter went over both VA, ECMO, and Impella, so I won't belabor the point. But as far as the ECLS shock trial is concerned, obviously this randomized patients to getting an ECMO or not getting an ECMO. And of course, reading between the lines and looking at inclusion criteria, I think is very important and answers some of the questions that were asked, why the difference in the danger shock or the mortality rate of the control group of the danger shock trial, which I'll get to. But I've highlighted some of the important criteria which were used in ECLS shock trial, and I think they were the reason for the result that we got from them. Especially, they included both patients with STEMI and non-STEMI. The lactate level was much higher some of the prior trial. And probably most importantly, they allowed patients to be enrolled of resuscitation up to 45 minutes. And I think that led to inclusion of many, many patients, probably up to 90% of patients who had altered mental status and some of whom had hypoxic brain injury. And of course, this is the baseline characteristics. You see almost 95% had altered mental status. More than 3/4, so almost 80% of these patients were resuscitated before the trial, and their lactate level, the mean lactate level was 4.5 in danger shock. It was 6.8, 6.9 in the ECLS shock trial. Equally important and somewhat puzzling, and maybe Professor Zamer can actually expand on this for me, the trial was designed to look at ECMO in cardiogenic shock, and only about 20% of the patient had the ECMO implanted prior to revascularization. This contrasts with 85% of the patients who had the Impella implanted in the danger shock trial. While the subgroup analysis did not show any difference, but once you dissect the trial and you become subgroup analysis, the numbers become too small to make meaningful impression of the trial. Equally important, the unloading or venting was only done in 6% of the patient, which obviously, when we look at the data of the combined meta-analysis that Professor Hogler and Zamer did, this becomes an important fact. As Dr. Peter showed, no difference in the 1-month mortality, 49% to 47.8%. I think it's important to point when the trial was designed, the investigator rightly estimated the 49% would be the risk of the control mortality. So they actually accurately estimated the risk of mortality in the control. What came short is the improvement of outcome that was expected in the active part of the trial. If you look at the subgroup analysis, unfortunately no change. Secondary endpoint, yes, both groups had lactate clearance, but unfortunately no change, and similarly for the renal function. Unfortunately, this came with a cost, 3 times higher than risk of peripheral vascular complication, and 2.5 times higher risk of bleeding, with numerical increase in the risk of a stroke, even though statistically not significant. Professor Zamer and his group then did a individual patient data meta-analysis combined with the 3 other small trials, and as you can see, again, no improvement in outcome of these patients. So ECMO did not improve the outcome regardless of the ECLS and the combined data, and of course, it came with a higher risk of vascular complication. Should this be used to change the current guidelines? The current guidelines is 2B. Should it be changed? Should it be a class 3 indication for ECMO? This is the 1-year result, and again, 1-year result, no change, 55% to compare to 55.8%. Again, no change in the outcome. This is not an individual patient data analysis, but this is danger shock compared to ECLS shock. And you see the difference between the patients that were enrolled in the 2 trials. You see the ejection fraction. Most importantly, you see the lactate, 4.6 compared to 6.8. You see the resuscitation, 21% compared to 77%. And you also see the time of the MCS initiation, 84% implanted before compared to only 22%. Could those have been the factors in the result of the trial? Regardless of the data you look, even in the danger shock, unfortunately, the mortality remains high. We do need circumscribed data because cardiogenic shock is expensive, especially in certain parts of the world is not available. This is the cost. This is a heart failure type of patient, but this is the cost of balloon pump, Impella, and ECMO, ranging from $130,000 to $190,000. So we do have to use them judiciously. And of course, most importantly, cardiogenic shock is heterogeneous. SCA shock classification has helped, but it remains heterogeneous. The most important part, I think, separating danger shock from ECLS is the involvement of cardiac arrest and hypoxic brain injury, because the mode of failure is different. In patient with out-of-cardiac hospital arrest is the brain injury, while in the patient with LV predominant STEMI patient is the refractory shock, and the mechanical circulatory support could help in those patients. Going back to the differences between danger shock and ECLS, I think one of the questions was the control arm had higher risk? This is the risk of mortality in the control arm of the danger shock and ECLS. If you look at the delta between the control arm of the ECLS and the control arm of the danger shock was not significant. It was only 3%. But the active arm was significant, 8.3%. So while the mortality rate remains high, the higher rate of mortality in the control arm of the danger shock does not account for the differences and the improvement in the outcome. This is the data that looked at all. This is published in Lancet just literally 2 months ago, looking at all the active MCS, and of course dividing them into loading and unloading devices. And at least in the true STEMI patient, cardiogenic shock patient, the unloading device, which is the microaxial flow pump or Impella, is the only type. So patient with ST elevation who did not have any hypoxic risk of brain injury, those were the patients who benefited from mechanical circulatory support. Unfortunately, the rest did not, and I think that's important. Given the heterogeneous nature of the patient, is important to separate these patients. So the question was raised, what to do with patients who have mechanical complication of an acute MI, and I think that needs to be a separate clinical trial. The hypoxic brain injury needs to be a separate clinical trial. Otherwise, if these are mixed, unfortunately, will not have conclusion that would be clinically useful.
Sir?
Yes. So this is actually the last slide. Is it the patient selection? Is it device? Is it revascularization strategy? Or is it unloading and venting? And I think it's all of those factors.
Thank you.